The traditional speaking valves currently on the market are flapper-type valves, which include those manufactured by Passy Muir and Shiley. The design of the flapper speaking valves, which has not changed since these were first introduced in 1985, includes a membrane or a diaphragm which flexes upon inhalation and allows air to pass through the tracheotomy tube. Upon exhalation, the airflow is reversed and the membrane closes with no air leak, causing redirection of airflow through the upper airway. These flapper valves are always 100% closed upon exhalation, a feature that is called bias closed, which means that zero air is allowed to go through the speaking valve upon exhalation. The flapper design valves have several shortcomings. The bias closed membrane of the flapper valves often cause a feeling of panic upon first-time introduction of the valve to the tracheotomized patient. This requires the speech-language pathologist to spend significant amount of time coaching and preparing the patient to the first-time introduction of the speaking valve. A certain degree of repetitive breathing effort by the patient is required in order to allow the membrane to flex and open with each inhalation. Since the average person takes about 20,000 to 30,000 breaths per 24 hours, the numerous repetitive efforts required to open the membrane during inhalation can cause a significant challenge to some of the tracheotomized patients, especially the young children, the elderly patient, and the patients with pulmonary compromise who tend to fatigue easy and are hence unable to tolerate flapper valves. One final significant clinical problem noted with these valves is that the flapper membrane tends to degrade over time with repetitive opening and closing, resulting in the uncomfortable honking or fluttering type of noise that is observed with a flapper valve that has been used for several weeks.